today. So my name's Dylan. I'm a junior doctor up in Sheffield. Yeah, and there'll be opportunities for questions at the end. I'll try and answer the best of my ability. So overview, these are cranial nerves, as you can see, and the Roman numerals. There are mnemonics out there. I'm not going to say, since it's recorded, what the mnemonic is that I learned to learn the cranial nerves, but there are mnemonics out there that you can look at your own leisure on Google to learn which order the cranial nerves go in. So introduction. So there are 12 bilaterally paired cranial nerves, afferent and efferent fibers. Cranial nerves 1 and 2 attach directly to the forebrain, and the rest come off the brainstem. Just as two terms to cover. So a nucleus, if I ever mention nucleus is cell bodies in the central nervous system, whereas a ganglia is a group of cell bodies in the peripheral nervous system. So afferent versus efferent, the different. So afferent is fibers going back to the brain. So sensory information from the head and neck going back to the brain. So these things like trigeminal nuclei. So mesencephalic, chief sensory and spinal trigeminal nuclei, vestibular cochlear nucleus, nucleus sartorius, which covers taste information. So these are afferent fibers. Here are the locations of the cranial nerve nuclei. So as you can see on the left, the afferent, and the right are the efferent. So I'll be bringing this diagram up numerous times during the lecture. So efferent nuclei, these are the motor ones. So the three types: somatic, branchiomotor, and parasympathetic. So these are your striated muscle fibers. The difference between somatic and branchiomotor is the cranial nerves that come from the pharyngeal pouches. So pharyngeal pouches is how in embryology, how the head and neck develop. And there are some cranial nerves associated with certain pharyngeal pouches. There's 6 pharyngeal pouches, and therefore the branchiomotor cranial nerves are the ones that come from these pharyngeal pouches. So the other, so the somatic ones are the ones mentioned up there. They're the ones that supply the extraocular muscles and the tongue muscles. You've got your branchiomotor ones, and then you've got your parasympathetic nuclei. So I know parasympathetic ganglia head and neck is a difficult topic to get your head around. Even I struggle right now trying to learn them for my MRCS surgical exams. So I'll try and cover those in a bit more detail. So starting off with olfactory nerve. So you've got the olfactory nerves, you've got the olfactory bulb, olfactory tract. This is what the olfactory nerves look like. They come from the cribriform plate. So the cribriform plate forms part of the ethmoid bone, and these project the first order olfactory nerves. Olfactory bulb is on the inferior surface of the frontal lobe, and then the second order fibers run in the olfactory tract back to the basal surface of the frontal lobe. And then most of these olfactory tract fibers run in the lateral olfactory striae to the primary olfactory cortex in the uncus. So I've just got a nice picture here. So there you've got the olfactory nerves of first order, second order olfactory tract running to the lateral olfactory stria back to the primary olfactory cortex in the uncus. As you can see in that picture of the brain, that's where the uncus is. And problems you can get with the olfactory nerve. So one thing you can get so we call anosmia, it's loss of smell. So loss of smell and flavors of food. Classically, with nowadays COVID-19, people get that, but other things that can cause that. So after a basal skull fracture can damage the olfactory tract. You can get meningiomas, which is a tumor of the meninges, and that can invade the olfactory tract and the olfactory nerves, and that could cause symptoms of anosmia. So that's the olfactory nerve. Optic nerve. Now, optic nerve is a very complicated, difficult nerve, right? You've got the optic nerve, goes back down to the optic chiasm. Optic chiasm, it gives off the optic tract. optic tract to the lateral geniculate nucleus. Lateral geniculate nucleus, you get the optic radiation and Meyer's loop. Now, one important topic in terms of optic nerve is optic nerve lesions. And here is a nice diagram. So if we look at number one, you get visual field loss, one eye, which called monoocular blindness, and that's when you get a lesion in the optic nerve. The second one is a lesion in the optic chiasm. Optic chiasm, you lose the temporal visual field, because if you remember, the temporal part crosses over at the optic chiasm. So you lose the temporal visual field, and we call this bitemporal hemianopia. And then any lesion further back from the optic chiasm, we get homonymous hemianopia. And that's what it looks like. So that's that diagram there. It's quite important that you get this around your head, because sometimes it comes up in spot tests, comes up in clinical exams. So like strokes, brain tumors can cause homonymous hemianopias. Bitemporal hemianopia, classic optic chiasm lesion, and then optic nerve lesion, monocular blindness. So just going over visual field deficits and monocular blindness, it can be disease. Don't forget, it might not be an optic nerve lesion. It can be disease of the actual eyeball, things like cataracts, intraocular hemorrhage, retinal detachment, and then also things like disease of the optic nerve can be like optic neuritis from MS, optic tumor. So again, bitemporal hemianopia, so optic chiasm, classically a pituitary tumor, or it can be a cranial pharyngioma. And then homonymous hemianopia, again, visual neoplastic lesions, things like that, vascular things. So could be an AVM, so atriovenous malformation, strokes, homonymous hemianopia. And just to go over Meyer's loop. So Meyer's loop usually does so you got the optic radiation and the Meyer's loop. The Meyer's loop classically does the upper visual field, and this sweeps around the temporal lobe, and they both terminate in the calcarine sulcus, in the visual cortex. Now, one thing you might come across is you might get what we call macular sparing. The reason we get macular sparing is the macula is supplied by the occipital poles. So if you see in the brain diagram there, it's 1, 2, 3, 4, and that does the central, the macular portion. Now that has a dual. There's a few theories out there why you get macular sparing from like strokes, and that's because one of the theories is it's got a dual blood supply from the middle cerebral and posterior cerebral artery. If you get an infarct in one of those territories, you've still got a blood supply from the other one, so therefore you get macular sparing in strokes and things. So that's one of the things you might hear is macular sparing in a stroke. And yep, so the cranial nerves classically go through the optic canal. This is where the optic canal is. So it's situated in the lesser wing of the sphenoid bone, right next to the ethmoid bone. You've got the other cranial nerves of the eye that go through the superior orbital fissure. So the orbit, the bones of the orbit is sometimes a quite difficult concept to get your head around. But yeah, it's made up of the frontal lobe, got the zygomatic bone, got the greater wing of the sphenoid, lesser wing of the sphenoid, got your ethmoid bone, and you got your maxillary bone. So yeah, so the optic canal is classically found in the lesser wing of the sphenoid bone, and that's what it looks like, the sphenoid. So you've got the greater wing in red, and you've got the lesser wing in green. There you've got the optic canal. Together they form that superior orbital fissure. Yep. Then you got the foramen ovale, foramen rotundum, foramen spinosum. And then the contents of the optic canal. So the contents of the optic canal is the optic nerve, ophthalmic artery, and the sympathetic nerve fibers that go to the eye. So they're the concept of the optic canal. So another thing is, so going over the parasympathetic ganglia, going over that. So you've got the ciliary ganglion, that's one of your parasympathetic ganglia. The ciliary ganglion is actually involved in the pupillary light reflex. This is when you're looking at the relative afferent pupillary defects and pupillary light reflex. So the afferent pathway, so the one going towards the brain, travels via the optic nerve. So when you shine a light, so let's say we shine a light in the right eyeball there, patient's left even, but we'll say right. The information will be traveling back to the brain via the optic nerve in the afferent pathway. It will go all the way back to the brainstem in the pretectal nucleus. So it'll go via the lateral geniculating nucleus and then to the pretectal nucleus. Here, the pretectal nucleus, it will synapse. It will synapse, and then what we call the Edinger-Westphal nucleus is bilaterally innervated from both sides. And then from there, it's traveled in the efferent pathway via the oculomotor nerve. It will go via the oculomotor nerve. It will synapse in the ciliary ganglion, and then it will travel via the short ciliary nerves to the muscles of the eye, causing pupillary constriction. Because it's bilaterally innervated, you'll get constriction in both eyes. Now, if you've got the relative afferent pupillary defect, when you shine a light on that right eyeball, you've got an afferent pupillary defect, so you wouldn't get constriction. And then you can look for RAPD. So that's the pupillary light reflex. And there in the brainstem, we've got a picture of where the Edinger-Westphal nucleus is relative to the oculomotor nucleus. So oculomotor, now moving to the oculomotor nerve. So the oculomotor nerve, it supplies all the extraocular muscles of the eye, except for lateral rectus and superior oblique. So, and it also does the constriction. So in an oculomotor nerve palsy, because the superior oblique and the lateral rectus muscle is still intact, you get the eyeball moving down and out, and you get dilation of the pupil. So that's the oculomotor nerve, because you've got that sympathetic innervation and no parasympathetic innervation. The other eye nerve is the trochlear nerve. Now that's the cranial nerve, and sorry, going back, oculomotor nerve runs through the superior oblique, superior orbital fissure. Trochlear nerve again runs through the superior orbital fissure. It does the superior oblique muscle, and this comes from the cranial nerve comes from the dorsal, only cranial nerve that comes from the dorsal aspect of the brainstem. And again, in this lesion of the trochlear nerve, you get diplopia when patients looking medially and downwards, and classically they'll say, I get double vision when I'm walking down the stairs, because that's what, when you walk down the stairs, you're looking down and you're looking medially. And they'll do a head tilt to try and correct that. So they'll head tilt, chin tuck. So head tilt will usually be away from the affected eye to correct that defect. So if you see this person in the diagram, head tilt is onto the right, the defect's on the left. The other cranial nerve is the abducens nerve. So abducens nerve does the lateral rectus. So the way I remember these two is SO4 from chemistry, SO4 superior oblique fourth cranial nerve, whereas LR6 lateral rectus sixth cranial nerve. Now, this is one concept which probably not important, but maybe for a bit of interest. So intranuclear ophthalmoplegia. This is where, like, you see it in multiple sclerosis, where you get lesions of the medial longitudinal fasciculus, the MLF. Now, MLF is used in coordinating eye movement in terms of turning your head, and it's the connections between the vestibulocochlear nucleus, the oculomotor, the abducens, and it makes like eye movements in coordination. Now, what happens here is the MLF is a connection between cranial nerve 6, the lateral rectus, and cranial nerve 3, the oculomotor nerve. Now, if you get a lesion in that, what happens is when you try and adduct to that eye, you can't adduct, and you get what you call nystagmus in the other eye. But then when you abduct, sorry, it works fine. So you can abduct, but when you try and adduct that eye, you can't adduct it, and you get nystagmus in the other eye. See, that's the defect. That's the defect in, and that's what we call intranuclear ophthalmoplegia. And then you might see it in conditions like multiple sclerosis. Now, going over the trigeminal nerve. The trigeminal nerve is quite a difficult nerve. It does sensory innervation to the face, and it also does other things like the motor innervation to muscles of mastication and a few other muscles. So the sensory nerve nuclei, there are 3 sensory nucleuses in the brainstem. You've got your mesencephalic nucleus of the trigeminal nerve. You've got your primary or main sensory nucleus of the trigeminal nerve, and you've got your spinal nucleus of the trigeminal nerve. And then you've got this trigeminal ganglia, which is, again, if we go back to what ganglia is, it's a cell body in the peripheral nervous system. And then you've got these branches of the trigeminal nerve, the 3 branches. So ophthalmic, maxillary, mandibular. But we're covering mandibular branch in a bit more detail. So ophthalmic branch, if we remember, goes through the supraorbital fissure. Maxillary branch goes through the foramen rotundum, and mandibular branch goes through the foramen ovale of the skull base. So if we look at the sensory innervation, so the mesencephalic, so the top nucleus, just going back to the mesencephalic nucleus, that does proprioception of muscles of mastications and the temporal mandibular joint. The chief or the principal nucleus does fine touch and pressure, when the spinal nucleus does pain and temperature. Now, the interesting thing is the cell bodies of all the nerves of these trigeminal nerves are located in the trigeminal ganglion, except for the mesencephalic, which is located within the nucleus itself in the central nervous system. And then also the trigeminal nerve does the motor, which is muscles of mastication, which are muscles of temporalis, masseter, medial and lateral pterygoids. Also does tensor tympani, tensor veli palatini, mylohyoid, and anterior belly of digastric. And there's a diagram representing the trigeminal ganglia. So if you remember, proprioception, touch and pressure, pain and temperature. So just going back, so chief, principal, spinal nucleus all have their cell bodies in the trigeminal ganglia, but the mesencephalic has a cell body within the mesencephalic nucleus. So proprioception of muscles of mastication and TMJ. Within the nucleus, you get the synapsin. So just going over the trigeminal nerves, so you've got your sensory receptor, you've got your primary neuron, travels to the sensory nucleus, the trigeminal nucleus, you get synapsin, you get your second order neuron, which then goes to the thalamus. The second order neuron, going back to that diagram, is the neuron that decusates, moves to the contralateral side, goes to the thalamus, specifically the VPM of the thalamus, the ventroposteromedial. The VPL part does the body, where the VPM does the face, and then you've got your third order neuron that goes to the actual brain. And then just going over the mandibular part in more detail, the mandibular nerve, the trigeminal nerve. So the mandibular nerve gives off, first nerve gives off inferior alveolar nerve. The inferior alveolar nerve, also sometimes I think it's called the dental nerve, because the dentist injects that to numb it. So numb their teeth for doing teeth extractions. So the inferior alveolar nerve has two nerves that come off it. Nerve to mylohyoid and the mental nerve. The mental nerve is a sensory nerve. It's called the mental nerve because it comes off the chin. It supplies the chin, the lower lip, and comes off the mental foramen in the mandible. And you've got the nerve to mylohyoid, which is the mylohyoid muscle. So nerve to mylohyoid branch of V3, which is the branch of the inferior alveolar nerve, which is a branch of V3, supplies mylohyoid and anterior belly of digastric. And then you've got another nerve, the lingual nerve. Now the lingual nerve, interestingly, it's a mixed nerve. It's got branches of V3 and a facial nerve. If you remember, V3 does general sensation to the anterior 2/3 of the tongue, whereas the facial nerve does the taste sensations from the anterior 2/3 of the tongue. But both of the fibers are carried within the lingual nerve. They're afferent nerves going back. And the part of the nerve that you might have heard of, the facial nerve, that actually does the taste from the anterior 2/3 of the tongue is the chorda tympani nerve of the facial nerve, which runs along with the lingual nerve together to do taste and general sensation. And also the chorda tympani nerve also supplies the submandibular and sublingual salivary glands, but we'll come to that when we do the facial nerve part. And here's just another picture of the inferior alveolar nerve running through the mandibular foramen, through in between the temporal mandibular joint, and then it comes out and gives us the mental nerve through the mental foramen. Right, now going over the facial nerves. The facial nerve comes off what we call the cerebellopontine angle. It has two parts. It has what we call the nervus intermedius, which does the sensory and parasympathetic, and the medial root, which does the motor. The sensory is anterior 2/3 of the tongue, taste sensation, and parasympathetic from the superior salivary nucleus supplies the pterygopalatine ganglion, which does the mucus glands of the oral and nasal mucosa and the pharynx, and the lacrimal gland. And also it's called the nerve that makes you cry, makes you, like when you cry you get mucus, blocked nose. There's the weepy nerve. And you've got your submandibular ganglion, which does the submandibular and sublingual salivary glands. And then it also does motor, which does the muscles of facial expression, the stapedius muscle. So if you remember, and the posterior belly of digastric and the stylohyoid. So it's quite easy to get the stapedius and the tensor tympani, the two muscles in the ear, mixed up in terms of innervation. So you just got to remember the stapedius muscle is facial nerve. Tensor tympani is actually your trigeminal nerve. And then again, anterior belly of digastric is your trigeminal nerve, whereas posterior belly of digastric is your facial nerve. So here's the facial nerve, runs through the internal acoustic meatus in the petrous part of the temporal bone, exits via the internal acoustic meatus to enter the facial canal. This is where the facial canal is. Again, like I say, there's two parts. There's the motor part and the sensory root, which is the nervus intermedius. Gives off these cranial nerves, so the greater petrosal nerve, nerve to stapedius, chorda tympani, nerve to stylohyoid, nerve to digastric, and then gives off the motor branches. So again, so going over the pterygopalatine ganglion. So pterygopalatine ganglion, like I say, the weepy nerve. So gives off the greater petrosal nerve, which does parasympathetic, and this is not to be confused with what we call the deep petrosal nerve, which does sympathetic from the internal carotid plexus. And again, these two go through the pterygoid canal, and collectively they're called the nerve of pterygoid canal. And then this nerve then synapses of the pterygoid ganglion and gives off, supplies the lacrimal gland and the mucus gland. So just to make you aware, at the parasympathetic ganglion, it's the sympathetic nerves run through the parasympathetic ganglion. They don't synapse, whereas the synapse are a bit further back. Whereas like the parasympathetic nerves, so the greater petrosal nerve, will synapse at this pterygopalatine ganglion. Ganglion is a collection of cell bodies in the peripheral nervous system. So the lacrimal gland, it's interesting. So pre-ganglionic part is the facial nerve. The facial nerve supplies the lacrimal gland, but post-ganglionic, it's actually piggybacks on the maxillary nerve and the zygomatic nerve, and that supplies the lacrimal gland. So pre-synaptically, it's the facial nerve. Post-synaptically, can get confusing, but it's actually the maxillary nerve that actually goes and supplies the lacrimal gland. And then you've got your mucus glands as well around your nasal pharynx, your nose. And then this going over the submandibular ganglion. This is where the submandibular ganglion is, just above where the sublingual and submandibular glands are. So the parasympathetic part is actually it goes down via the chorda tympani nerve, and then the chorda tympani nerve actually does the taste sensation, and it also supplies to the anterior two-thirds tongue, and it also does the submandibular sublingual ganglion, and then supplies does a submandibular ganglion where it synapses and supplies the submandibular and sublingual glands. And then the motor part, just to go over it, stapedius, stylohyoid, posterior belly of digastric, musculofacial expression. And to remember the branches, I learned to Zanzibar by motor car, which is temporal, zygomatic, buccal, marginal, mandibular, and cervical. So they're the branches of the motor. So let's just go over the picture there. So that's the facial nerve. Okay, so one thing you might hear in clinical practice is upper face and lower face, and sparing of the upper face. So the way that works is because there's actually, the face is split into half, and the upper face has bilateral innervation. The lower face has only unilateral innervation. So if you had a lesion presynaptically in the central nervous system in the brain, because the upper face is bilaterally innervated, because in the facial nerve nucleus is split into two, upper face, lower face. Upper face bilaterally innervated, you still get innervation from the other side, and you'll get frontal sparing. Whereas lower face is only unilaterally innervated, you'll get a droop. And this is a classic thing that you get in a stroke. Whereas if you've got a postsynaptic lesion, then you do not get frontal sparing. You get a droop on both sides. So I hope that makes sense. So now going over the glossopharyngeal nerve. The rootlets come off attached lateral to the olives of the brain stem, and it's got sensory innervation. So sensory taste and general sensation from the posterior third of the tongue, sensation of the pharynx, and then chemoreceptors of the carotid body and baroreceptors of the carotid sinus. And then it supplies motor to the stylopharyngeus muscle. And then this nerve has the parasympathetic innervation. Presynaptic ganglion comes to the inferior salivatory nucleus to supply the otic ganglion via the lesser petrosal nerve. Postganglionic fibers from the otic ganglion then jump onto the auriculotemporal nerve and supply the parotid gland. So if you remember, otic ganglion is the parotid gland, and this is the lesser petrosal nerve. So don't get that mixed up with the greater and deep petrosal nerve. The lesser petrosal nerve from the inferior salivatory nucleus via the otic ganglion does the parotid gland. So the thing you might hear in practice is Freyr's syndrome. Now, Freyr's syndrome is if after a parotidectomy, so like say the auriculotemporal nerve will originally will supply the secretomotor innervation of the parotid gland. However, after parotid surgery, these can reattach to the sweat glands of the cheeks, and this can result in originally someone who's not had parotidectomy, you'll get when you're eating food, you get salivation, but after parotidectomy, because they then reattach to supply the sweat glands, it results in they will get sweating around the cheeks when they eat food. And that's Freyr's syndrome.